The incidence of pulmonary embolism, PE, in the UK is 7 to 8 cases per 10,000 people annually, with approximately 35,845 hospital admissions reported between 2022 and 2023. Incidence rises sharply with age. Under 40 years, incidence is only 1 in 10,000. Over 80 years, incidence is 1 in 100. Common presenting symptoms. The most frequent symptoms include sudden shortness of breath, particularly at rest, 78 to 81% of cases. On exertion can be COPD, pneumonia, etc., but SOB at rest in particular makes PE more likely. Chest pain, 39 to 56%, often pleuritic. Syncope, fainting, 22 to 26%, particularly in older adults. Haemoptysis, coughing blood, 5 to 7%. 94% of patients exhibit at least one of these symptoms: missed diagnoses and mortality. Missed cases, at least 400 deaths in England and Wales from March 2021 to April 2022 were linked to PE misdiagnosis. Mortality sheet. Untreated is 17% all-cause mortality at 3 months. Treated, mortality drops to approximately 1% in low-risk patients, but rises to 10.9% in high-risk cases. Older age, heart failure, and hemodynamic instability increase mortality risk, high-risk demographics. Age, incidence peaks in those over 80, with a 100-fold higher risk compared to younger adults. Sex age variations. Younger men more often present with haemoptysis. Older patients, both sexes, frequently experience syncope. Early recognition of symptoms like sudden dyspnea or chest pain is critical to reducing mortality. Misdiagnosis remains a significant concern, often attributed to non-specific symptoms, being mistaken for conditions like chest infections or anxiety. Efficient risk stratification is crucial to avoid unnecessary computed tomography, pulmonary angiography, CTPA, thereby reducing radiation exposure in patients. This diagram suggests a possible algorithm for the low-risk patient who presents with possible pulmonary embolus. You would first apply either the Wells criteria or the Geneva score to help stratify the patient into low, medium, or high risk. There is a simple way to remember the Wells criteria which I have adopted. Feel free to use this memory aid if it helps you. If you first consider the 2 high-risk clinical features, if there are clinical signs and symptoms of a DV as a PE results from an untreated DVT, or if the clinician feels PE is the most likely diagnosis, Gestalt. Both of these give 3 points. You then consider high-risk features in the patient history chart or observations. This has 3 factors, which is immobilization status for at least 3 days, a personal history of DVT-PE, or a tachycardia. Each of these being abnormal gives 1.5 points. Finally, you have 2 features which the patient can tell you: haemoptysis or malignancy. Each of these gives 1 point. As the slide shows, only a Wells score of 0 or 1 is low risk, 2 to 6 is intermediate risk, and greater than 7 is high risk. The Geneva score is more complex and harder to use, but for a purely algorithm-based system or a more junior clinician, it can be more objective, as it does not contain clinical Gestalt, and instead, on top of Wells score, it includes a few other risk variables, such as age over 65 for a point, unilateral leg pain for 3 points, and 2 extra investigation findings, PA02 less than 8 for 3 points, and atelectasis on chest X-ray for 1 point. It further stratifies scoring of heart rate. For the Geneva, a score of 0 to 3 is low risk, 4 to 10 intermediate risk, and over 11 high risk. With the simplified Geneva score, every variable scores 1 point, and 0 to 1 is low risk, 2 to 4 intermediate risk, and 5 or over high risk. Using the clinical decision aid flow tool for patients that are deemed low risk by either the Wells score or the Geneva score, we can use the PERC tool to exclude PE without even needing to do a D-dimer or further imaging. While clinical judgment still needs to be used, one can use these decision aids as a guide to anchor on. H. ADCL-OTS is a useful mnemonic for PERC as illustrated in this slide. Hormone use, age over 50, DVT-PE history, coughing up blood, leg swelling, oxygen saturations less than 95%, tachycardia greater than 100, surgery or trauma. If any of this is positive, then PERC is positive and one needs to do a D-dimer, but if all negative, one can avoid D-dimer. There is an easier to remember approach called the Years algorithm that aims to reduce the complexity of Wells and Geneva scoring without losing sensitivity and specificity compared to the above. This has only 3 criteria: clinical signs of DV, Haemoptysis, and clinical Gestalt, suggesting PE as the most likely diagnosis. If no Years criteria are present and D-dimer is less than 1000, PE is ruled out. If any Years criteria are present and D-dimer is less than 500, PE is ruled out. Evidence from a meta-analysis of 12 studies supports Years as an effective strategy to optimize PE workup. Van der Hulle et al., Lancet, 2017. Years achieves 97.4% sensitivity versus 74.4% for Wells, better excluding PE in low-risk patients. Successful implementation examples include Dutch EDs, where Years algorithm adoption resulted in a 17% reduction of unnecessary imaging. D-dimer has a good sensitivity. 95% of patients with a DVT-PE will have a raised D-dimer. However, it has a poor specificity. Many conditions like pneumonia, heart failure, malignancy, pregnancy, etc. can cause a raised D-dimer. One can adjust the D-dimer for those over age 50. This gives a higher specificity. Age-adjusted cutoffs, patient age times 10 micrograms per litre for greater than 50 years, reduce false positives by 18 to 67% versus fixed 500 micrograms per litre, especially in older adults. Sensitivity is maintained with a 97.4% sensitivity in meta-analyses. This approach leads to 20 to 67% less CTPA scans in patients over age 50. A meta-analysis of 47,720 patients showed age-adjusted D-dimer ruled out PE in 97% of cases with no increase in false negatives. The Relieve PE trial showed a 1.3% missed PE rate with age-adjusted cutoff comparable to fixed. The conclusion seems that age-adjusted D-dimer is a safe, cost-effective strategy to exclude PE in low to moderate risk patients greater than 50, reducing unnecessary imaging while maintaining diagnostic accuracy. None of these rules trump clinical judgment and are adjuncts. High clinical suspicion mandates imaging despite low scores. We will conclude with a visual summary of the various decision tools and approaches. In future videos, we will discuss treatment approaches as well as risk stratification once a PE is diagnosed.